To all of our viewers on the call this morning, we would like to welcome you to our Men's Health segment, where the topic is Let's Get Serious About Men's Health. We welcome you with our partnership with AARP, as well as the National Black Nurses Association, specifically with the First Coast Black Nurses Association, seated here in Northeast Florida, Jacksonville, Florida. This morning, we have the privilege and distinguished honor of being graced by the presence of some of the most notable physicians here in the Northeast Florida region. I'll start by giving you their names, and then we'll follow with their bios. First, over here, seated to my left, we have Dr. Kenyatta Lee. And beside him, we have Dr. Cain. And then we have Dr. Kenneth Jones. And then lastly, we have Dr. Renard Rawls. We'll start off with the bio on Dr. Cain. Dr. Cain is a South Florida native and has been in the Jacksonville area for more than 30 years. He is in a private practice sector as a family practice physician. He graduated from Florida Agricultural and Mechanical University from the College of Pharmacy and Pharmaceutical Sciences, and he was also in the first class of the Morehouse School of Medicine. He was the chief resident of the University of Florida Health Hospital here in Jacksonville, Florida in 1988, and he is the president emerita of the Northeast Florida Medical Society. Next bio we have is for Dr. Kenyatta Lee. Dr. Kenyatta Lee began his professional career at the University of Florida Health here in Jacksonville, Florida, within the Department of Community and Family Medicine. Dr. Lee is an American Board of Family Medicine certified physician. He completed his undergraduate degree at Cornell University, finished at Mayo Medical School, and concluded with his residency at the University of Pennsylvania. He has also earned his master's in health sciences and clinical leadership from Duke University, and Dr. Lee is currently in private practice at Pareto Clinic, which is seated at Edward Waters University here in Jacksonville, Florida. The next bio we have is that of the general surgeon, Dr. Kenneth Jones, who has been in practice for over 40 years. He is a fellow of the American College of Surgeons, as well as being board certified in surgery. He's a graduate of Cornell University in 1974, as well as a graduate of Cornell Medical College in 1978. One of his notable honors that he is most well known for is that he was the first African American to do a kidney transplant here in the state of Florida. He currently practices general surgery at Ascension St. Vincent's Hospital. Lastly, we have Dr. Renard Rawls, gastroenterologist. Dr. Renard Rawls graduated from Morehouse School of Medicine in 1997. He completed his internal medicine training at the University of Florida Shands Jacksonville Hospital in 2001 and went on to complete a 3-year subspecialty fellowship in gastroenterology with the University of Florida Shands Jacksonville Hospital. Dr. Rawls is a board-certified gastroenterologist and has been practicing with the Boylan Groover Clinic for the past 17 years. Gentlemen, we welcome you and we thank you for joining us this morning. With that being said, let's get started. First, we will direct questions to Dr. Cain. With your current practice within the primary care family medicine setting, what do you tell your non-compliant patients with elevated blood pressure levels as well as who might have elevated blood sugar, blood glucose readings?
You may wind up having a stroke, you may wind up having a heart attack because you are those two conditions that you just mentioned, elevated blood sugars and elevated blood pressure, hypertension, and diabetes are two of the primary risk factors in cardiovascular disease. There are multiple other risk factors with cardiovascular disease. And by the way, cardiovascular disease is sometimes used interchangeably with heart disease. And to be quite frank with you, they are not the exact same thing. You can have, heart disease is a form of cardiovascular disease, but also cardiovascular disease can also include stroke, okay, kidney dysfunction, peripheral arterial disease, you name it, and one of the probably one that most men recognize easily is erectile dysfunction. Because all of those risk factors tend to affect the lining of your blood vessels. They increase the deposit of cholesterol in the lining of those blood vessels. That can cause some inflammation in the lining of those blood vessels. That inflammation can cause enough damage to the lining of that artery that it prevents that artery from participating in lowering your blood pressure. With the high blood pressure comes along and the high cholesterol together, it may come along and get some cholesterol plaque build up. Those plaque build up can be sheared off by that high blood pressure going across those plaques. And depending on the top of those plaques, whether or not they got a cap that's a thick cap or thin cap, can increase your risk for whether or not it's a heart attack or a stroke. And when it comes down to stroke, it can talk about whether or not it's a bleeding stroke that many people recognize that's versus a stroke that just has obstruction of blood flow. And the same thing can occur with a heart attack because a blood vessel is a blood vessel. Regardless of where it's at, you're going to get a similar effect within whatever organ it may be in terms of what the effect of or the damage to that particular blood vessel. Again, if it's in the brain, then you're going to get a stroke, okay? Might be a bleeding stroke, or there might be one that was just obstructed because of some clot or another. If it's in the heart attack, if it's in the eye, you can get, retinal disease and damage. Kidneys, you start getting kidney dysfunction, so it's quite a bit that can go on. And I go down the line with these patients and explain to them why it is that if you don't control these items, along with the other risk factors that they may have, okay, then they may increase their risk for injury or death. And as I was saying when I first started out, somewhat jokingly, it may not be death, it can just be injury. And then that leaves you've seen people with strokes, you've seen, how they walk, how they talk, if they can walk and if they can talk. You've seen people with stroke that also may not be displaying any physical injuries, but they may have a lot of mental damage. You can have them with what we call vascular dementia. I know a lot of people know about Alzheimer's. When they hear Alzheimer's, it's like, ooh, But, vascular dementia is just as prevalent in terms of causing memory-related disorders. And again, it's all because of the effect of the 5 major risk factors for cardiovascular disease, i.e. damage to those blood vessels. Those 5 major risk factors would be diabetes, high blood pressure, dyslipidemia or elevated cholesterol, smoking, and your family history in which that you had a relative 65 or older, younger, 65 or younger that has suffered from they say heart attack, but again, I go right back to a heart attack can be, a brain attack can be just as indicative of a high risk factor from having as a heart attack can. So, I don't want to steal all the thunder that my colleague here has because there's so much that we can talk about with that. He and I can go back and forth in discussion a heck of a lot. So I'm going to let you go to the next question. And he may want to even join in on this particular question.
Certainly. So with that being said, and you mentioned risk factors and some comorbidities and multiple chronic disease states, within your practice, what would you say are the top medical conditions that affect men of color specifically, and what measures of prevention do you feel should be implemented?
I kind of alluded to them just a few minutes ago. High blood pressure, dyslipidemia, elevated cholesterol, and diabetes. Those are the top 3. And I would, as my practice age, and I'm really aging myself, but I've been in Jacksonville since '84, so longer than 30 years, longer than 35 years. But as I've aged, so has my practice. And so 60% of my patients have those three items, okay, together, because I got a senior practice. And the alarming thing is that I'm seeing it in a whole lot of young folks. I mean, a whole lot of young folks that we used to didn't see this, okay? They're eating off cholesterol row. I call that Don Avenue, but these days you can find it. Anyway, they're eating all their meals and stuff outside. It got worse with the pandemic, obviously, but it was pretty bad already. And unlike their parents, whom a lot of them say, well, my mom, my dad ate, greasy meals and fried foods. It's like, yeah, but they got out there and they worked, okay? They might have worked the fields, much like I did as a youngster and my mom and dad did, so they kind of burned off a lot of that stuff. But most of our jobs these days are very sedentary. They don't want that sun, they don't care about that sun, and so they're not in a hurry to get out in the sun and work.
Thank you for your input. Dr. Lee, I will direct this question towards you all. As you said, both you and Dr. Cain serve primarily in the primary care setting. What do you feel that providers can do within their capacity to improve their ability to just kind of improve men's health overall?
I think that's a great question. And the context for me is the idea of chronic disease as a issue that exists within our country. So we know 75% of what is disease in this country really is chronic disease. And what we have are systems of care delivery that are really set up for acute care management. So skin infections, pneumonia, these acute presentations, but never structured to manage longitudinal disease. We've turned hyperlipidemia, diabetes, into chronic HIV, some cancers, into essentially what are chronic diseases. So what we know is men are canaries in the mine. You had miners who would go in and you could just imagine them with a bird cage and a light on their head. And if the canary died, then we would run before Joe fell down because he was a little hypoxic, he smokes. Yeah. So, that's the reality of what you see with men in men's health, the global picture. It is as much a systems issue as it is, but it is not just a systems issue, it's a men's issue. We know that men are less likely to get physical exams. Women, if I'm honest with you, 70% of my practice is female. And it starts probably when many of them go into prenatal care and they build that rapport with their physicians. And we know that in that space, men don't do that as frequently. There is that feeling of big boys don't cry. And I always have this idea, don't come in too late, don't wait till it's too late, because a lot of what Dr. Cain has talked about didn't start when, it started way in advance. The stroke, the brain attack, the heart attack, the peripheral arterial issues start in advance. We know that men tend to be uninsured and are more likely than women to be uninsured, and so that gives an issue. And even those that have what we call good insurance, they still don't go to the doctor with the level of frequency that they should. And then we know that men, because of these behaviors, die 9 times out of the major 10 causes of death. We win 9 out of 10. And the one we lose in, I guess, is Alzheimer's disease, which women, that's because they just outlive us. So a lot of what we're dealing with is a systems issue in terms of how we modify practices. And what I love about what's happening the 21st century is this idea. Churchill said that Americans will always do the right thing after they've exhausted all other opportunities. So what you have is a major pivot towards value-based care. This idea that you just can't churn and see a bunch of people. You have to ask the question, not just how many did I see today, but how well did I see them? And then actually having metrics that allow you to measure that. So the point being that, one, men should seek to find care in environments where they know that there's value. So you have a Dr. Cain who's sophisticated, aware of his metrics, engaged with his practice, really committed. That's the type of physician that you're looking for. So making sure that they're really careful about how, just as they would select a mechanic, not under a tree, with that kind of thing, but they're probably going to go to the dealer or mechanic that slightly specializes in that automobile. They should be thinking of their health in the same way. You think about and that systems-based issue is there. So, and I think when we think of what the patients should do, obviously they should find providers that are committed to that. They should look at their chronic diseases, be actively involved with their physicians, have expectations, shouldn't smoke, shouldn't drink, should exercise, and do all the things that they should do. I think those are the biggest issues that really jump out at me when it comes to men's health. But the other thing is when providers are looking at what they should be thinking about. So if you're thinking from a health systems perspective, you have to be thinking, how are we managing chronic disease? Do we have systems in place? Do we have case managers? Do we have nutritionists? Do we have, certified diabetic educators? What systems do we have in place to make sure that the population that we're responsible for is actually doing well? The individual provider would have that same responsibility. So that's been my experience with chronic disease, especially as it relates to men.
Awesome.
Adam, before you go on, I think both myself and Dr. Lee, we're both talking about prevention.
Absolutely.
We want to make sure people keep that in mind. You don't wait until your engine run out of oil to go get your oil change. Because otherwise you won't have an engine very long. So you go out there, you get your oil change on a regular basis. You should get your oil change on a regular basis with somebody like him or myself. Go see your doctor on a regular basis so they can do a checkup, see what's going on, catch it before it happens, as Dr. Lee was alluding to. And then when we do that, we are less likely to suffer the long-term consequences of those disease states.
Certainly. And one final question for you both before we move on to our next segment. When we think about now with the World Health Organization and how they kind of speak to the social determinants of health, there are many, and we do not have enough time to touch and go through them all, but specifically the question is designed towards, in looking at social determinants of health, within your practice, what are some things or that you either challenges you've come across or some barriers that you have overcame? Specifically, I'll just speak to you as it regards to maybe access to care, whether that be something as simple as transportation or whether that be something such as food insecurities.
I think one of the biggest problems when you look at social determinants, we can talk about insurance, that's a big deal. So you have a disproportionate number of men that don't access care because they don't have but it's so interesting is that with Marketplace and all the other insurance products, it's not that expensive. I see them in beautiful vehicles. They sometimes have beautiful motorcycles with the little jackets with their name on the back, Butch, Joe, Fireman, Hot kind of thing. But the amount of resources that it takes to do that kind of thing is no more when it comes to getting your numbers, right? What's your cholesterol? What's your blood pressure? Most of the medicines are generic and incredibly inexpensive. So that social determinants piece is people who don't have access to that, don't have information, education, and all those bits and pieces, and don't always have access to doctors and physicians. What I would say is they're actually good physicians here and not tolerating anything less than what you would expect or just demand just because you geographically may not have access. Look for a good physician just like you would look for a good person to do your hair or to cut your hair or do whatever. So I think we could get into the mechanics of education and other issues related to social determinants, but that's what I'm seeing and experiencing, just letting them know that you can get the care you need even if you don't have the resources. And when you get that care, make sure it's the right type of care and that you're actively involved in understanding what that information is. And if that person doesn't have the time to walk you through what's going on, then that's not the right person, for you in getting your care. And when they find a good person, stick with that person. Show up to those appointments and do all the stuff that send them to Dr. Rawls, who will do an awesome colonoscopy on them. And if they need any surgical, that kind of stuff is really important. So that's
awesome.
My perspective.
I will also draw on that to say, even though access is there these days, that people have somewhat access, the Accountable Care Act, it was great, but sometimes it may not be the Affordable Care Act. Not so much affording the insurance, even though, they can still be relatively expensive. But should the person get insurance, then, how good of insurance do they have in terms of being able to get things done they need to have done? I hate it when the sales reps come in my office and want to pitch these new drugs on me, particularly if there's a generic equivalent. And that's a no-brainer. I go with the generic equivalent. But when there is no generic equivalent, and they give you these very high prices on these drugs, and the first thing they say, look, it's only a copay of $45, a month. And it's like, yeah, but that goes along with the other 6 or 7 medications that person need. And, because average African Americans need 4.5 medications to control his or her blood pressure. So that, 3.5. But that's still quite a few, and that means that's an added cost. Even if they're only $10, there's still another $45, and which they have, they'd have to pay out. The other thing, when you start talking about the other social determinants, you start looking at access to foods. Again, we go back to proper foods and being able to eat, proper meals. The cholesterol content is one thing we talked about, but the sodium contents in those cheap foods can go through the roof. And of course, as African Americans, especially African American males, we tend not to pay as much attention to the sodium content of those foods as much as it is about the dollar amount of those foods. So it's quite a few things.
Thank you for you all's input.
The other piece is stress and stress mitigation and how they manage stress. And what we see a lot of is using the tobacco products, using the alcohol products and every various type of alcohol, whether it's beer or liquor or whiskey or rum, consuming those beyond where they should be, using cocaine, and heroin, which are obviously wrong things to do, but how do you mitigate that stress? And then how do you engage, whether it's working with your primary care physician and there's a, antidepressant, or whether there's some counseling, whether it's going to church, whether it's doing push-ups, whether it's whatever it is in terms of facing the demons or whatever that drive the decisions that will ultimately produce a lot of the chronic disease that we're dealing with. So I think that's the other part of it with the men's health piece, and certainly social determinants.
Take-home points and foundational points of both of you all's great input into the discussion is prevention from a primary care standpoint, and making sure that in order to kind of mitigate risks, if you will, definitely having a prevention based mindset in the care that you all provide to your patients. In the realm of prevention, we have to address screenings. There are many different screenings that are recommended with the clinical guidelines, specifically with this segment on men's health, colorectal cancer screening being one. Of course, we know prostate cancer screening, of course. But specifically, I guess we can kind of highlight one of the major screening tests that I guess in society, unfortunately, may be frowned upon, but is colorectal cancer screening. So, Dr. Rawls, I guess we will direct some of the questions towards you, and just kind of say, overall, what are some things that you would say that patients overall can do to decrease their risk of developing colon cancer?
Good morning, and thank you for that kind introduction earlier, Adam. Certain things that we can do to decrease our risk of colorectal cancer. We talk about diet. We want to limit the amount of red meat in the diet. This also includes processed foods, hot dogs, sandwich meat. We talk about fiber intake. We want to increase the amount of fiber in the diet. We recommend at least 25 to 30 grams of fiber a day, even more. Those things help decrease the risk of colorectal cancer. Also, regular exercise. Find some routine, something you enjoy, whether it's walking, some folks enjoy running, aerobics, something that you will continue and get into a routine and continue that makes a big difference. Also, we mentioned, as mentioned earlier, maintain a healthy weight throughout life and limit the amount of alcohol and eliminate tobacco. Those things, those few things, they make a big difference when it comes down to colorectal cancer.
Certainly. Thank you for that. Just, I guess, overall for our viewing audience who either one has already heard the encouragement from their primary care provider of them receiving a colorectal cancer screening. Two questions for you. First question being, can you just give just the viewers just a brief overview maybe of what the specific procedure of a colonoscopy is, so we can kind of maybe, break some myths and maybe offer some relief?
Absolutely. It's a simple exam. Basically, the day before the colonoscopy, there's a prep. Back in the old days, we used a gallon of what we call Go Lightly, and it would taste like salt water. It's hard to make it through that, but nowadays it's a lot better. We have preps with low volume, and they're split dose, so you're not taking a lot at one time. When I say prep, that's a laxative we take the day before to kind of clean out the colon. And the following day, you come into the office, we place a small IV, we get the medication through the IV, and you sleep throughout the entire exam. Most patients say it's the best sleep they've ever had. And once you're nice and sleepy, we take a thin scope with a light and camera on the end, and we have a look throughout the entire colon. And if we see any polyps, they're removed at that time. And that eliminates future risk of developing colorectal cancer.
Awesome. And so you as you mentioned, based on the findings, I guess would determine maybe how often the patient would have to receive routine screening, correct?
Absolutely. Depending on the size of the polyp, the number of polyps will determine when you would come back for the next exam. And when we mention a polyp is basically a precancerous growth which can develop on the wall or lining of the colon. And over time, sometimes it takes 10 years, sometimes 15 years, it's slow growing, so it gives us enough time to go in and remove these polyps before they develop into cancer. And that's why the screening is so effective and important to do.
Awesome. My second question to you, for those patients who, for whatever reason, despite us breaking some of the myths today and hopefully easing some anxiety that patients might have towards getting their colonoscopy, for those who just are still adamant about not wanting to go through with that procedure, while we certainly do not endorse any specific company or any specific brand or medication, can you just speak to some of the at-home testing that is offered to patients for colon cancer screening? Just briefly.
Yeah, absolutely. Well, what I would like to say first is the colonoscopy is the gold standard because it's the only test where you can not only prevent colorectal cancer, you can diagnose it and prevent it with the colonoscopy examination. So I think that's the gold standard. There are other screening tests that are available. You probably have seen the commercial, the Cologuard, which is a stool-based test. It checks for cancerous DNA cells and blood in the stool. It's recommended in average risk patients, so if there's a family history or if you had polyps in the past, you wouldn't qualify for that particular test. And then we have other imaging tools for screening, what we call the virtual colonoscopy. Sometimes we can check stool for occult blood. So there are other tests that are available for screening, but the gold standard is still the colonoscopy examination, and that's what we recommend.
Certainly, certainly. Thank you for your input. And so just briefly, as of course we're delving into men's health specifically, with the current screening guidelines that you all follow, what rough age range roughly would you gauge where you recommend your patients receive screening?
Yeah, going back a few years ago, a little bit longer, we used to start the screening process at age 50, say 5 to 10 years ago. And what we realized is that there were a number of patients who were being diagnosed with colorectal cancer at a much younger age. And with advanced disease, especially in our African American population. And so initially the American Cancer Society recommended that we lowered the screening age from 50 to 45, where it is at this point. So this was initially recommended for African American patients, and now it's actually recommended for all patients. So we're starting that screening process at age 45. Colorectal cancer is the third most common cause of cancer here in the U.S. and the second leading cause of cancer deaths. We have roughly a 4% lifetime risk of developing colorectal cancer. Last year, there were 150,000 cases of colorectal cancer diagnosed, and unfortunately, over 50,000 deaths. And we ask, why is that the case? And that's mostly due to late detection. Colorectal cancer in the early stage is 90% cured with surgery alone. We send them to Dr. Jones, and he takes it out, and they're fine in the early stage. But as the cancer becomes more advanced with regional spread, that cure rate drops to 70%. And as it gets more advanced with spread to other organs, say the lungs or the liver or the brain, that cure rate drops all the way down to 12%. So that's why early detection is so important. And we talked about the colonoscopy examination, which can not only detect colon cancer at an early stage, but it can prevent colon cancer altogether with the removal of the polyps. So that's important.
Certainly. Thank you for your input. Is there anything else you'd like to add or address?
Well, one thing I would like to say, some of the symptoms we see with colorectal cancer, we may see a change in the stool caliber. We may notice thin stool or new onset constipation, abdominal pain, weight loss, or blood in the stool. But these symptoms usually occur late in the disease. We really want to diagnose colorectal cancer at an early stage when it's treatable, when it's curable. So you don't want to wait until you get these symptoms before going out for your screening exam. You want to get this, you want to have your regular screening exam starting at age 45. And if there are patients who are higher risk, if there's a family history of colorectal cancer, we actually start at age 40 or 10 years younger than the family member at the time of diagnosis.
Okay. Thank you for that. So, again, kind of the underpinning tone of prevention, early screening, and detection across the board for all comorbidities and chronic disease states that unfortunately most of the male and specifically African American male patient population suffer from. Unfortunately, as we know, there are instances, as you said, Dr. Rawls, where patients, might receive kind of screening on the back end, after they become unfortunately symptomatic. And you do unfortunately have some of those urgent emergent issues or cases where, unfortunately, some form of acute intervention is needed, such as surgery. Dr. Jones, I guess we will kind of move on with you and just start off just saying, could you share any possible potential complications of surgery from patients with any of these kind of chronic disease states that we mentioned at the beginning of the segment, such as obesity, heart disease, hypertension, or even patients who might have unfortunate, GI issues or the like?
Well, first, thank you for the invitation. There are a number of potential complications associated with obesity. For instance, the most frequent cause of post-operative wound infections are patients who are morbidly obese. And it has been well documented. We have had patients that we have refused to operate on because of their level of obesity. Because not only you're concerned about the wound, you're also concerned about the fact that postoperatively their breathing may be compromised. So when we have those patients, we immediately send them back to their primary and ask the primary to put them on their medically supervised weight reduction diet, if we have that much time. And we explain to the patient the reason why. Now, like America, I could tell someone you're not a candidate given your present condition, but they will find someone else who may say it's okay, especially if they have insurance. So many times we find out on the back end they went somewhere else, they had a major complication, and then the family comes back and say, well, why did that happen? And we say, well, we told you that would happen if this person had surgery at this time. One of the other complications that we see, and some things that we are concerned about, is patients with uncontrolled, long-standing hypertension and diabetes. You'll be amazed someone comes to have surgery, and the nurse will come out and say, Mrs. Such and such or Mr. Such and such, blood pressure is 210 over 100. Really? So many times we would call the primary, we'll explain to the patient, we need to send you back to your primary, who more than likely send you to the emergency room. So we see those complications. Many times, post-operatively, patients who have coronary artery disease or long-standing hypertension, the three that we look at, smoking, hypertension, diabetes, and obesity. Those four things, if you have even elective surgery, we're not talking about emergency surgery. If you have elective surgery, your probability of having a complication is significantly higher. If you have if you have all four, it's awful to have an operation. So we rarely operate electively on people who have those four. Severe obesity, morbid obesity, uncontrolled hypertension, uncontrolled diabetes, and that they smoke. They are guaranteed to have severe complications. Luckily, we have a lot available if you smoke. There are many programs now to help you with that. The primary care physicians are so astute at this that they can take these patients and get them into what I consider good management, which is getting them with a dietitian, making sure that they take their medicines. And that's important, making sure that they take their medicines, because compliance is very important. So from a surgical perspective, we send many people away from elective surgery because I know that the complication post-surgery would be such that this would not be a good outcome. So it's very, very important that we address the primary care issues in these patients before we undergo a surgical intervention.
Certainly. Thank you for that. Just briefly, just for the audience, just a brief example, if you can, of just some elective surgeries. We know the list is ongoing. Elective just versus, as you said, acute or urgent surgeries.
Well, the one I would think of most is, say, hernia repairs. Hernia repairs are completely elective if you don't have incarceration or obstruction. And if you have a morbidly obese person who shows up that wants to have their hernia fixed, you could say no. Now, many times because of our practice, we see patients who've had 3 hernia repairs and they've all come back. And then they come to us for the 4th repair, and the conversation goes like, the reason those 3 came back is because 1, you're smoking, or 2, you're a diabetic and your diabetes is now well controlled, or 3, because of your truncal obesity, there is no material that we can use that would keep that hernia from coming back. So you have to be honest with the patient and their family up front about what the expectations are of surgical intervention.
I know one of the things I see a lot of my patients, speaking of curing the disease but killing the patient, is that with the knees. you know, when they get ready to do knee surgeries, a knee or in need of knee surgery. The surgeons refuse to do the knee surgery because they haven't lost enough weight for them to be able to, for the joint replacement to withstand that kind of weight. It's just going to give away, and it was a useless, I'm going to say useless, in the fact that it won't work as long as they want it to, or may have all kind of complications. That's one of the most common ones. And I see quite a few of Ken's patients, and he's here more of mine, that fit in the scenario where you talked about a hernia. When they have those hernias that sit there and they want them repaired and they want to go to someone else, and yeah, they'll go, you know, if that guy has a bill he want to pay, yeah, he'll do your surgery. But then you're going to need to get another surgery to fix the first surgery.
Exactly. We see a lot of that. And one of the things we also hear about, too, is the fact that the morbidly obese person that needs to have a knee replacement, where one surgeon says, you know, you're really not a good candidate because of your weight. The other surgeon says, you know what, if I fix your knee, you'll be able to exercise. Absolutely not. It does not happen. So I think that good, honest conversation and dialogue with your patients is very important. That means creating a relationship. That is why they need to have a primary care physician.
Certainly.
That absolutely, I mean, all the things we've talked about here, I think it goes through the purview of the primary care physician, who goes ahead and manages that patient to the level where they can have a procedure safely.
Well, certainly. Thank you, gentlemen, for your input. And it kind of, as you said, Dr. Jones, all ties back to having that open, honest conversation, but kind of taking that step to establish a relationship with your primary care provider who can then link you to, as said, the appropriate specialists, subspecialists that are indicated at that time. With that being said, we can kind of maybe take a step back and kind of maybe walk through the steps for patients who say, well, hey, you know what? I just got a new job. I finally have health insurance. And, you know, I'm kind of ready to be seen, or unfortunately, you might have that patient, you know, of course, given, you know, the circumstances as we're coming out of the pandemic that are saying, hey, you know, I had to change jobs. I'm kind of in between jobs and currently uninsured, but still need my medications refilled, or, hey, you know, I've been having this problem that's kind of been going on for the past 6 months or a year. Can you, if at all, speak to any resources that you're aware of within the Northeast Florida region as far as whether it be healthcare services directly or just any other community services, case management, home health, or anything, if you can speak to either resource within the community?
Well, there are quite a few. There are quite a few resources out there in terms of volunteers in medicine, Agape, as far as it relates to federally qualified health centers, Schellsbacher. You know, so there are resources out there depending on what that person needs. If it's related to HIV, there are various HIV, Ryan White, and some of the other ones out there. Be honest with you, the people can look to the First Coast Black nurses, can give them guidance to where else they can look, because a lot of times they do not have a primary care physician. We are, and we failed to mention it before, we are a part of the Black Physicians Network here, which is the Northeast Florida Medical Society. And many of our members are aware. It just doesn't be these guys up here that know about it. Boylan Groover, at least once a year, does a whole lot of charity-related cases. Maybe more than once a year, but Dr. Rawls can speak more to that. So there are plenty of them out there that can give help. And what we have to do, you just have to know and go and look in the right places. Again, easy resource to start with is First Coast Black nurses.
I think,
you know, what I would say, please do not use the emergency room to get your health care. I think in Jacksonville, we have the federally qualified health centers, Agape. That's family care. If you do not have money, you do not have resources, I think you can start there. But please do not use an emergency room for your primary care physician. That is not the place you want to go. Okay? And remember, they still do send you a bill when you leave there.
A huge bill.
Very, very large bill for something your primary care doctor or a place like Agape would provide for you at a reasonable cost.
At a fraction of that cost.
I think that's exactly it. Don't use the ER. The continuity is not there. Great institutions, the Salzbacher, the Agapes that are there, which are awesome. I think, and for the uninsured in that space. But the other piece is when you do have insurance, this is like amazing in terms of the type of care that you can get. Big sophisticated systems. You have Baptist, you have Ascension, you have the UFs of the world, all which are providing incredible care and lots of primary care. And you have private practices that are providing exceptional care as well. So you have a spectrum of places where you can go and seek care. What I would argue is that you're meticulous about choosing the people. Dr. Jones mentioned the value of that relationship. It has to be a good connection where you're connected with that person, you like them, you're really literally trusting them with your life and putting your life in their hands, and it needs to be a relationship that you have confidence in, that it's really going to be somebody who's advocating and fighting to produce the best outcome possible for you. So we're blessed to be in this part of the country because we do have a lot of resources.
I can't let it slide without at least mentioning that other resources can include many of the insurance providers.
Yeah.
You know, AARP, Florida Blue, Humana's. They can at least give them some direction as to who to look up. And I have many patients that say AARP sent me, because I ask them, how do you get to me? You know, so you can look to them. There's a lot of resources out there. You just got to look for them. And as they said, even the hospitals themselves. There's 5 hospital systems in this county. That's I don't want to say it's unheard of, but that is a large number. It's very unusual to have that many hospital systems, and each one of them has some primary care basis to their institution. So.
And they're really close to each other when you think about it from a driving perspective.
Yeah.
But as was mentioned earlier, I think that organizations like AARP have a lot of resources. And remember, you don't have to be 65 to join. You can be a lot younger to get those resources.
Yeah, they reminded me when I got old.
So they remind you could join at 50.
Yeah, that's right.
But they have resources, and I think that's something everyone should know. And they're free resources, even though the membership is negligible. But they have those. They have the capability for you to go online, see what they have, healthy living, healthy lifestyle, which is one of the most important things. I mean, we've talked about it. I don't care how many tablets you take. If you're still eating a half slab of bacon every week, that's not going to help you. So I think it's imperative that we start investigating quality lifestyle as we go down this journey of improving our health, improving men's health.
I think what I always find interesting is when my patients bring those little AARP pamphlets into the office with them that they've marked up and highlighted, diabetes, Dr. Lee, what's my A1C? Right. It really is a cool thing. So knowing how to engage, leveraging resources to understand how to really query to get the most out of your provider, this is your life, and it's worth it. And that's a solid piece to get it.
I do have one other resource that I probably didn't, and I'm going to say it real quick because I'm trying to be cognizant of time as well. Believe it or not, clinical research. There are plenty of organizations doing clinical research. A lot of times clinical research can provide some care. I'm not saying that's where you want to get all your primary care, anything along that line, but sometimes they can provide some resources to help get you started in a certain particular direction. Of course, it is best that you have a primary care to help guide you through those clinical research providers. But when money becomes an issue of particular disease states, and there are studies out there that provide some materials and treatment for it that you can't afford otherwise, it's a good avenue to at least entertain.
Certainly, thank you, gentlemen. And while we do want to mention AARP, The First Coast Black Nurses Association is part of the National Black Nurses Association, as well as the Northeast Florida Medical Society, do not endorse any specific resource. We will, just as a courtesy to the viewers, just offer a listing of some of the community resources available within the Northeast Florida region. With that being said, gentlemen, I would like to thank you all for your time, for your input, and for your much needed expertise in the realm of healthcare, specifically with men's health, and even more so specifically within the African American community. Before we leave you all today, I would just like to give each and every one of you just an opportunity to leave a final point or remark, if any, just in regards to whether it be a message you'd like to get across to patients within the Northeast Florida region.
Yeah, I discussed the screening colonoscopy earlier, and we mentioned some of the symptoms that go along with colorectal cancer and the age, 45, in which we start the screening process. But I do want to stress, if you're having symptoms and you're not 45, don't wait until you reach that age. And there are a lot of folks that say, well, I'm only 25, I'm 30, I'm 40. Go have it checked out, because you never know. In the screening process, it saves lives.
My recommendation to the audience is establish a very good working relationship with your primary care physician. I think it starts there. That's the entry to the healthcare system, and you will be a healthier person and hopefully live longer if you have a good relationship with your primary care doctor.
And to piggyback on that, as a primary care physician, me personally, and I also know as well as Dr. Lee, who has the same access that I do, we know very, very good specialty physicians, okay? 2 of whom are up on the stage. And we wouldn't hesitate to send my mama, my sister, my brother, any of our kinship to. And if you want to judge a primary care as to how good they will help you matriculate the system, ask them will they send their mama, sister, brother, son, daughter to that specialist.
I don't think I can add more than that, but great relationship, a relationship with somebody who you trust will send you to great specialists, and make sure that the systems are 21st century type stuff, that they're looking at and thinking globally, that you get that access where you're calling and reaching a person and you can do walk-ins and you can do all that stuff if there's an issue that pops up. So a great relationship with a physician that is really solid about that will set everything in the right direction. So that's it.
Awesome. Well, gentlemen, thank you for your time.
Thank you.
And attention towards the matter on Let's Get Serious About Men's Health. We certainly, again, just thank you for all your expertise and input. We would like to thank AARP again as a sponsor, as well as in working with the First Coast Black Nurses Association as part of the National Black Nurses Association, as well as, we cannot forget to mention, the Northeast Florida Medical Society. We thank you all for your time and for your viewers. Good afternoon.
Good afternoon.
So you've been watching the show. Would you like to be a content provider yourself and develop a show for the Inspire Network? Please give us a call today at 904-389-5592 or go to www.connecttv.info to